together. So I'll turn it over to you, Roger.
Great. Thank you, Wendy. Hello, everyone. Again, I'm Roger Chauffnier, part of the consulting team that's supporting this initiative. We're going to be talking about leadership. Let me make a little bit of a breadcrumb trail of how we got here and why we're talking about this. As part of our early work, we've been supporting this initiative to try to figure out how to best meet all of your needs in terms of your priorities, what you've identified in the change plan, your local capacity, your experience in many of these areas. And that shifted some of the thinking very early on in terms of how we were going to approach the rollout of your various initiatives. I think initially that there might be a one-size-fits-all that we could have everybody come to the table and participate in, and that didn't really reflect your local priorities and needs. So what you've seen over the last 6 to 9 months has been a series of activities to focus on capacity building, on identifying and tackling areas that you identified when we came together. We brainstormed in our kickoff meeting a series of topics and areas that you identified were important. And based on that, that's how these various lands and individual learning modules played out. When we first introduced the basics course on QI, we weren't quite sure how many people would sign up, and it was oversubscribed. And then the second one being oversubscribed. So it clearly was reflecting a need that is in the field, and hopefully that's responsive. When we support various improvement initiatives based on all of our work across the country and also well embedded in the evidence base, what we find from very successful initiatives and very unsuccessful initiatives, that leadership is a core driver. And a lot of it has to do with what we'll be talking about today, which is, oh, just turned it off, it looks like. What we'll be talking about today is alignment and alignment opportunities. And we're going to talk about internal alignment. How does all of this work fit into your internal priorities and can better be aligned? And we're going to talk about external alignment. What can we do together to really move the big dots? You are working in an initiative sponsored by the state, and they have a series of big dots that they're expecting you to move. When I say big dot, I mean some measurement objectives. There are some areas or priorities. We're going to show some of the data. You've all seen the data in the past. But one of the questions is, how's all this fit together to move those dots? One of the dangers is we become very transactional. And so you send people to a LAN, or you send people to a training program, and we have Confluence working on this, another group working on that, and all these kind of tornadoes spinning, working on things, with people getting exhausted, but the dots don't move. And we don't seize the opportunity to look beyond just our assets as individual organizations, but what is the collective impact that we can have as a group? How can we start to meld some of these opportunities so they're very synergistic and working together? So I'm going to follow a little bit of an 80-20 rule. This is not going to be a dog and pony show with a lot of slides. It's going to be a dialogue. So I'm going to share a couple of key concepts, and we'll share some data, and we'll dive into a discussion about the so what. So let's start, if I don't turn off the slide deck. Let's talk about internal alignment opportunities. Now, when we talk about internal, what we mean is, how does all of this work align internally from your strategic level all the way down to what people are working on and participating in these learning activities. I was very fortunate early in my career to have the opportunity to work with 3 of the major gurus in quality improvement, a guy named Phil Crosby, Joe Duran, and Dr. W.A. Bruce Deming. And I remember having lunch with Phil Crosby, and he wrote a book called Quality is Free, and suggesting that every dollar you put into quality improvement, there's a significant return on investment. It hits right to your bottom line. And he was the chief quality officer for General Dynamics and was very involved in their turnaround of the company, and spurred a whole series of different programs. Zero defects came out of some of his language, having a zero defects day in the organization. So he said, quality is free. The next week, I had lunch with Joe Duran, and Duran is saying, you know, quality is not free. Quality will not happen by accident. And he was saying, all these people are going around with these slogans and these activities, but if you're really going to achieve quality, you have to prioritize. You have to drive it in the organization. Don't assume that you put someone through training with quality improvement, they're going to run back and apply it in their work. You have to drive it through the organization. So there's a little bit of a, let's see here, what did I just do? There's a little bit of a graph here that says, in an ideal world, when you talk about how all of this aligns, you would be able to really understand the needs of your environment, your community, your internal operations, your competitive position, all of those factors, regulatory environment, all of that going into what we call profound knowledge of your patients and your environment. All the community needs assessments that are required by the IRS for hospitals, for example, how that all feeds in. That should create a vision for the organization of what you want to work on. And that should ideally be cascaded down through the organization. When I was doing Baldridge work years ago, in Baldridge, they used to teach us to focus on approach, deployment, and results. So when you hear about this new method, it could be human factors engineering or whatever new method is coming along, what's the approach? What's the methodology there? How does it differ from what we're doing? What pieces can we take and apply? And then how well deployed is it through the organization? I often go in and do site surveys, and I talk to the leadership team, and I hear all these great things, and then I go out and talk to the secretary and say, oh, I'm really impressed. You're doing this and that. And they go, we don't do that here. All right? But here's a vision, but it's not cascading down through the organization, right? And then if we're cascading, we're putting all this time and energy, where are the results? Is it translating into results, right? Now, I bring this up because already in the trainings we've done, we've seen a little bit of this phenomenon of a national distribution curve where there are a lot of people coming in really excited about the training, and I really want to learn more about this, and I'm very passionate about it. And then you have the rest of the curve that's saying, yeah, I'm glad I'm here, but I'm not quite sure. I got this memo saying you're going to be at a training Monday, and I'm not quite sure where this fits into my real work. So can you help make sense of this for me? And that's a sign of alignment. That's a sign of how are we cascading down from our strategic plan to our internal priorities in the organization. Ideally, it should fit into a master strategic plan. So one of the questions I'll be asking is all the things that are identified by the healthcare authority and the state and what you're working on here as a group, where do they fit into your strategic plan? Some of you have tied them directly. Some of you may not have strategic plan, depending upon your organization. But if not, then how's it translating into an operating plan? And that operating plan informing your budget and you're adequately resourced for what you want to work on. And then how does that connect to your internal improvement efforts, your internal quality efforts? So some of you have quality committees and they have their own work that they've been doing. And all of a sudden this initiative comes along. And the question is it tied to that internal initiative? Is it something that the metrics that you're proposing in this initiative are things you're going to be tracking through your quality committee? Or is this going to run as a parallel initiative with staff saying, now which one do you want me to work on right now? Which priority? And the reality is we all have so many competing priorities, it's really, really tough to keep this all in place. So let me just stop there and ask you, how are you creating the breadcrumb trails to connect the dots? What examples are there of this work that you're doing, the learning activities that you're participating in, your change plan? How is it fitting into your internal strategies and messaging and what we say and do and work with the staff? What sharing would you have of how to connect those dots with the staff so they're not showing up with a memo in hand saying, I have no idea how this fits in, but instead saying, okay, I know I'm here for this purpose, and when I go back, this is how it's going to fit into some of my work, and that's how it's connected to our change plan, which is connected to our strategy, and that's why we're focusing on this. What are some of your thoughts? How are you connecting the dots? Thank you all for coming. Have a good day. Any thoughts?
Hey, this is Chris Debilanu with Catholic Charities.
Yes, sir.
One of the things that we've done is that we've taken the vision of what change can be and what patient-centered mental health is and went back to the board and really outline for them what the vision is, where this is going to go over the next 3 to 5 years, and got their buy-in and support from it. And now we're turning around using our coaching and consulting and the strategic plan in order to then educate staff on what we're doing. So that's kind of where we're at right now, and it's been something that I think is starting to take hold and given us an opportunity to start sharing that vision with staff as well.
Any other thoughts?
I think for Grant Integrated, what we did was we took where we were, or the vision that we already had, and tried to make sure that the things we were doing in the change plan were in line with that. So we've had some of these visions. We'd had conversations with a local medical provider about this before it was cool. So I think we started from our change plan from what vision we already had.
Super. Other thoughts?
Just in general, I mean, and it's very much in general, not specific here, but I think where we fail is systems. We may understand it up at our level.
Oh, yeah.
We don't answer the why for our people who have to implement it on the front lines, and that's probably the most important, is answering the why.
Yeah.
Why are we doing this? It's, okay, you threw the vision out, now I got to follow up, but it's just another thing for me to do. So if we don't answer the why to begin with, and then they can learn, is really the number one thing. It's going to get us through over our barriers.
Yeah, really, really critically important. So a simple thing like you have people registered for an upcoming workshop, being able to reach out to them, having someone in leadership saying, you're going to this workshop, do you have any questions? Do you understand the context of what you're doing? You understand the expectations? And you know how this is going to fit into the rest of your work. That little piece goes a tremendous way in linking people in and helping answer that why. There's a famous quote from a former Mayo CEO that said, attention is the currency of leadership. And so what you pay attention to and what you say is what people will focus on. And when your senior leader, all of you in leadership, reach out and make that connection, it's very powerful. So I said we'll talk 80-20. That's about the internal alignment. So be thinking about sustaining that over time. Don't take it for granted. I fall into the Duran camp of everybody doesn't have my accent, you have to really drive it. So stay on that piece. So let's really focus on where some opportunities are on our external alignment. So there is a series of cascading effects happening nationally. There's a national quality strategy that's published every year by the White House and HHS that sets the national priorities. A lot of it come from the public health initiatives, but that sort of sets the overall tone. That ends up providing guidance to various grant programs and activities that are being rolled out across the country. That should connect to the state priorities, and the federal government works on those state priorities. In theory, those are connecting to regional priorities, and then those connecting to what you're working on as a group here. All those priorities, in theory, should start to really inform what we're working on in terms of future learning activities. So this first 6 to 9 months, we've been working on the capacity building part. But as we transition now, we're moving into these bidirectional lands that's starting to the rubber meeting the road now. Of how do you apply some of this into actual changes in how are we delivering care? How are we optimizing our staff? How are we building in the evidence base? What are we measuring and how are we using that data to drive improvement? As we start to move forward, we need to make sure that all of that translates into those big dots, if you will. So let's see what the data tell us. Now this is going to be a little bit hard to see. So this screen behind me is probably the better one for those in the room. But this is data that has come from the Healthcare Authority that provides benchmark for how you're performing in your region under the accountable community compared to the state on various activities. You'll see green, yellow, and red. The green is your head, yellow you're behind, and red you're last, or you're the lowest performing ACH region. So I'm going to walk through the 3 slides. There's 3 of these slides so that you can see the different measures. But I'd like to facilitate a dialogue on which of those dots should we be moving? How do we move them? And where do these various learning activities fit in to help support that work? And are there new learning activities that the management team for the ACH should be focusing on for how we can really move those dots so that all of this work is translating to impact?
Just I'm curious, I mean, this is really hard to interpret, just ACH is us.
That's
So what you're telling me is there's a really narrow margin of deviation under antidepressant medication. We're
Small
at
margin.
47. Yeah, so we're worse, but 49, I mean, is the average.
Right.
So, okay.
right. There's a small.
Nobody's doing this well.
Nobody's
what
doing
this
it
is
well.
saying. Okay.
Right. So I think it's important to look at the relative comparison, but also the absolute performance. You know, if we're performing in the 30s or 40s, some of them 24% follow up on discharge, 23%. That means 75% of the patients aren't getting the follow up. That's an issue in itself, right? Whether we're better or worse than the rest of the state, that's a challenge. So this is the first slide. Any questions on any of these particular performers? Have most of you seen this data before? You've all kind of seen it. Okay. Let's look at the second one then. Medication management for people with asthma. Now there's a little bit more of a delta there, 25 to 31%. So that, you know, that raises a flag for me saying, this is a potential opportunity for collaboration. And then you have substance use disorder treatment penetration, 22 to 28%. And this is whether—
What exactly does that mean?
As I understand it, Caroline is looking up the thing, but as I understand it, these are people who have been identified. There's actually a claim for these people with a diagnosis of substance abuse, and this is whether they are getting the follow-up treatment that has been prescribed or ordered for them. Is that basically—
From primary care to SUD, is that, or ED to?
So let me read the metric description. Percent of Medicaid beneficiaries aged 12 and older with a substance use disorder treatment need identified within the past 2 years who received at least one qualifying substance use disorder treatment during the measurement year. And the qualifying substance use, they have a list of qualifying treatment, but it's all based on claims data. So what was your question, Paul?
Is that from a medical to us?
So
I mean, I would think
it
if
would be
we,
somebody—
is that how many people walk out of treatment? What is that?
So people who go to you, they would show up as a qualifying.
Right.
What else is qualifying? Can you just read that out
Let's see.
again?
Let me
It's not
open my
hard.
comb. So,
I don't know if it's a good assumption, but it sounds like it's based on claims data that anybody with a diagnosis, whether it's in primary care or in behavioral care that's picked up, then are they getting the treatment? Having been identified, are they getting the treatment? Whoever's prescribing or managing it, is it being done?
Right. Well, and
so
that's what I'm trying.
it's a brief, a SBIRT, a medically managed detox service, an outpatient encounter, and then, you know, they reference all these value sets for coding and such probably from the claims data.
Yeah, I just curious if a primary care doctor's saying we're working on decreasing your opioid use or blah, blah, blah. Is that ever going to show up in a claim? That would, you know. So I'm just curious how this is measured, that's all.
Mm-hmm.
There might be times when a service was provided and for one reason or another, no claim was submitted.
So this is a really important point. There are many, many reasons why these things happen, right? And you know, historically, there's always a tendency to say, well, you got to understand, you know, our population has got issues, blah, 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 blah. There are a whole variety of things, from documentation, where are things put in the electronic health record? Do the claims actually get submitted? What other issues are going on, social determinants of health? I mean, that whole variety of issues, all that can be attacked. And when you start to focus on those things, you actually can see those dots move pretty quickly. If you clean up the administrative side, just in terms of the documentation, sometimes you end up finding that you're better than the rest of the state. And you can start to prioritize what are those things that are actionable that we can't control right now, and what are things that we could collaborate on. So for example, you have our work that is going on with the lands, bidirectional lands. You also have a social determinant effort going on. You have transitions going on. All of those could be aligned to help support a particular metric like this, if that's what you wanted to prioritize. The question is, how do you do that? How do we break across silos to make sure that we are really driving towards that common aim and using our data to point us what the priorities are, and then what actions do you want to support in the field to bring that together? So other thoughts, and let me just do one more graph here. So we have substance use disorder penetration. We just talked about medication management for people with asthma. Any questions on that one? All right.
Roger, can I comment on your last question?
Yep.
You said a lot of this is cleaning up the administrative part of it, and there were a number of calls for coding training. And I think what you're hinting at is that, you know, the care may actually be getting provided, but not billed correctly, coded right, et cetera, and that there may be some work to do just to clarify where the problems are, and they may be different in different organizations. Is that a fair?
Exactly. That's a great example.
Exactly the question I was asking.
Yep.
Just got to identify, you got to understand the measurements so you can understand where you're failing.
So here's, I think, data continuing. Follow-up after hospitalization for mental health, 7 days and 30 days. 7 days is other one. Oh. And then these are the pay-for-performance measure dashboard from the state. And notice medication management for people with asthma. So that's on both measures, and asthma looks like a potential ripe opportunity. Substance use disorder treatment penetration and substance use disorder penetration for opioids. All areas where there's opportunities. So the question is, a couple of questions. One is, so what are the priorities? Are there opportunities to start to look at one or two of these areas where we might create alignment and leverage, and start to look at how we can bring the collective energies of the group to start to shift and move those data points, to make sure we have very clear alignment of what people are participating in, what they're focusing on, what internal quality improvement priorities there are, all of that moving in a common direction. And being very mindful that there are opportunities to go beyond your walls and also partner with other people who may not have been as close to the table. For example, the payers. What's going on with the payers and their own initiatives trying to tackle these things where they're being held accountable to the state for their own work. Other community-based organizations that you could start to leverage. A group I'm working with in Oregon started this process, and they developed their measure set of what they're focusing on, and then they went to their community-based partners and said, what metrics are you accountable to various stakeholders? And what could we do to align some of that? So out of that conversation came some metrics that they were all collecting, but doing it individually and not using it synergistically. And then out of that conversation, a very key service that was being provided by the county was shutting down for a few months because of lack of resources. It happened to be a WIC program. And in that particular county, they had a YMCA that was starting a new child service where they could provide daycare for those same kids. And they hadn't talked to each other. Yet they're all working in the community on an opportunity. So that's the synergy that we can start to create to say, what could we do together on these particular dots? Asthma might be an example. A group in New York City that we worked with was really trying to focus internally on their asthma program, couldn't understand why their asthma is one of the worst in the country. Well, it turned out they were next to a big trucking depot where trucks were all coming into New York City to unload all their goods and services, and trucks are sitting there idling out in the parking lot, creating all this fumes and gas that kids are walking by on the way to school that's a couple doors down the street. Well, that required working with a trucking company to put in a protocol to turn off the engines when the trucks come in. And all of a sudden they saw the amount of kids coming into the ER, lost school days, other things diminishing. That's low-lying fruit, right? Doesn't require a lot of expenditure or resource, but it does require coordination and does require being on top of it. So let's open it up. What are some of your thoughts? We can go to any of the metrics. What are some of the alignment opportunities using this collaborative here to really drive substantive improvement in the population that you're serving? What are some thoughts? Any areas you want to?
Well, I think the first one that sticks up to me is the communication from ED usually happens with the primary care, but not with behavioral health entities a lot of times in regards to admissions, whether it be mental health or substance use. So that communication, that coordination usually, well, obviously can be improved, but usually doesn't happen, you know? I think that one's pretty, I mean, it could be low hanging. Obviously, there needs to be some consents that need to be signed, but, you know. But
So,
I think it was on the other one.
Follow-up.
It was follow-up.
I think it was like, yeah, follow up.
Yeah.
I think it was the last one. I was looking at Grant County going, wow, there's a lot of red.
so this one?
No, keep going.
Thanks, Mike.
I'm not sure where it was, but it was,
Yeah.
you know, historically though, that, you know, ED communication with the primary care happens. But for behavioral health, you know, admissions, a lot of times that communication doesn't happen.
So that the whole follow-up area, 7 and 30 days, is real ripe fruit. And those are process breakdowns. I mean, there's some issues with the patients and there's social determinant issues that
Yeah, absolutely.
can always there, but often they can be the outliers. It's often our system process because there's just no mechanism to communicate, right?
Right.
So how might we be able to tackle something like that? What's a collaborative effort that we might be able to work on?
Well, we've got our other transitional care management. I mean, everybody discharged in the hospitals locally are going to be getting phone calls. So that should help, and primary care could be worked into that. We've also got Eddie. Every group should be able to access Eddie from their own clinic and just figure out if they've got their own clients or patients into the ED.
Is behavioral health getting them pre-managed?
We've talked about,
We just haven't pulled the trigger. We're still trying.
yeah, we've talked about working with
Because
the
that right
NCOs.
there is,
Yeah.
that be slam dunk. And that is a quote unquote low hanging fruit that we're trying to work on as an ACH. We've had several discussions with Collective Medical Tech to figure out how to help providers get connected with pre-manage, and whatever your barriers are, like it sounds like some of you have tried, but if we need outside resources to help you like punch through that barrier so you can get your client file uploaded and then start receiving notifications, then that would be a great step. So that's something that in the survey we had distributed, we asked folks to identify how interested they were in getting help with pre-manage, and many fell in the extremely interested and interested buckets. So we're gonna follow up with you as soon as we kind of have a coordinated approach to rolling that out. So that is something we're working on.
I think one of the challenges we face is we've got this desire to be more integrated and to break down barriers and have the communication flow. And then we've got people at the state of Washington who say, if you share any behavioral or God forbid, you know, substance use information, you know, you're going to jail or, you know, all these other things. There are barriers that are conflicting.
Mm-hmm.
And we can certainly and should work on this regionally. And I'm sorry, I'm a broken record. Linda, you know I said this.
I delivered that message.
So somebody's got to get the state to get their act together. And if the state wants us to integrate, then everybody in the state needs to help us integrate. Instead of some areas of the government saying, we are watching, and if you do something we don't like, you'll pay for it.
Well, we're still stuck in the fee-for-service world.
Right.
We are paid to see these patients and not paid to manage them outside. The Medicaid dollars are incredibly low, and to try and, you know, so how do we solve this? And we need our MCOs to come on board to say, how can we provide this data to you too? At the same time, they know who these patients are assigned. I mean, we need, it's why this whole ACH exists, right? How do we solve this issue is what we're getting to. So it's a
Yes.
big nut to crack.
I think a related issue with that too is, for instance, with the measure for depression medication follow-up. If we're going to be whole person health, that means we need to acknowledge the fact that there are going to be patients who are better served by a non-medication solution to their depression. But there's not a way for us to be able to show success with that necessarily, to be able to say we've met the end game, but we didn't do it with the measure that we're trying to be told that we have to, in order to be successful at that measure, it must be a medication solution. And some of those things, we're, again, just like we're caught in that whole fee-for-service world, we're also caught in a traditional medicine world where there are ways that we can be handling this. How many of the people that are not following up with their substance abuse issues have transferred into a church-based support group or something like that may be more productive for them to do than in a primary care, that we just don't send that information to the MCOs to be able to track our success rate with those.
So in working with the health centers in Oregon, they moved into an alternative payment model and liberated them from the fee-for-service encounter. And said, we'll no longer tie payment to the encounter. We're going to tie it to a series of metrics here. We still have to submit your claims, but you're free now to use alternative visit types. So they've come up with 27 different alternative visit types. And the issue came up, we're going to have to tackle, how are we accounting for clinical productivity? Maybe our traditional metrics are not going to do it. We have to start changing some of those metrics. So they've started systematically collecting data on all of those alternative visit types, which could be a church visit, it could be a community health worker in the community, it could be others. So if that was a priority that you said, this is something we need to get data to demonstrate to the state to influence the system, then let's work with our health plans and come up with V codes or alternative codes or whatever way to track it, so we can start to show the impact of some of these things and influence how we might be tracking clinical productivity.
Well, another challenge is, and Rick touched on it, we're still living in this fee-for-service world, especially as it relates to paying people. Most providers are either on a full production kind of compensation plan or a salary, and then once you get beyond a certain point, then there's so much per encounter or per RVU, and we are kind of bipolar. Luckily, we have behavioral people. But that's a learning process, and I think we're going to have to figure out how can maybe we incorporate some things that aren't just production.
Yeah.
Maybe we choose some of these measures and say, okay, this is part of the comp plan.
Yep. So another aspect of that is that we often don't fully appreciate and understand the impact of some of this on the clinical productivity from a financial perspective. So there's no way to reimburse for these alternative visit types, but if you're able, since you have so much demand for services and needing, especially in the behavioral health, if we can shift some of these visits that are low intensity and clogging up time into alternative visit types and replace those with higher intensity visits, it actually may help your bottom line rather than be hurting it. But we kind of get stuck on there's no code, there's no way to get reimbursed for this service. A great example in South Carolina, a clinic was integrating behavioral health into primary care, and the state was not, they thought the state was not reimbursing for that. And they went ahead and did that, and their revenue and productivity skyrocketed. That so many of the primary care visits were being caught up with the provider trying to deal with behavioral health issues, that when they turfed that off to the behaviorist, it was able to dramatically improve. They also found out that the state was paying, and that they left several $1 million on the table because they hadn't done their homework on what was reimbursed or not. So these are the kind of things that we can start to drill down and say, okay, as you said, let's take a measure, whether it's asthma or another. Let's really do a deep dive as a collective system. Think if 5 years from now this project really has a huge impact, and the state shifts to value-based reimbursement in some big way and saying, you know what, we're going to carve up the state and ACHs are going to get a lump sum payment and you guys go manage the population. You've demonstrated your ability to work together. And you're now in a position in a total premium role, similar to an ACO. Then how are we going to be ready for that? How are we going to manage that? Is there a way to get an on-ramp here and demonstrate how we can collectively move that dots? Other thoughts on some of the data, or what you saw, or priorities, or how we can collectively work together? So we heard about the transitions was an area that sounds like that there's some work that's underway currently, but could be built on a little bit further. There's some alternative information systems that people may or may not be, Eddie and others, that fully utilizing. What would it take to accelerate some of that work so that those measures you might be able to see some movement over the near term? Any thoughts?
This is Tracy at Mid Valley Clinic, and this has been talked about at the TCDI conferences or phone calls. But I wanted to really bring it up again is one of the difficulties that we face here with our patients is we are not getting notified when a patient is discharged from an inpatient facility. Typically what happens is the patient just shows up in the clinic and says, I'm out of my meds, I need to be seen. And this has become really difficult for us because even at the point where they show up and we try to get records from the inpatient facility with the signed release of information, we still don't get them in a timely manner. And so this is not only a huge issue for us in providing timely care, but it's a safety issue for patients. How if we can't get the records, if nobody's even telling us that they're being discharged, how can we effectively treat the patients with the unknown amount of medications that they were discharged on? So I think, for us, and I know it's not just us, there's a lot of people that are dealing with this, but we really need to get some ground with the inpatient facilities in our state to help us help our patients.
Is there any information from the payers? I've worked in other environments where some of the payers are sending notification directly to the providers. Are there any systems or anything else you can weigh in on? Go ahead.
Well, I was just going to say, in terms of many of the HEDIS type performance measures that you see here, we do have the ability, especially those that are claims-based or administrative, we do have the ability to generate them, and we do typically where we have providers that are already working with us in a value-based arrangement, try to share out, and more on the primary care side, share out where we have gaps. So members are assigned to XYZ health center, and we see that client is missing this service, and we could be communicating that. And the other thing I was going to mention in terms of the conversation right now, I think it was about inpatient data, that now finally the clinical data repository is live with the state. So it seems like something we should be researching to figure out what is available in that CDR in terms of standard information that we can pull back out, hopefully to have the clinics have more visibility of some of what's recently discharged, what that discharge summary looks like.
So obviously, if we're waiting for the encounter, it's going to be too late. But you all are getting usually notifications on the front end if somebody's being admitted as a payer, either through pre-auth or through
medical technology, like Caroline already spoke to, is for the state of Washington, every hospital is, I believe, reporting through CMT. So that's really a huge asset here in the state for us to be trying to make sure we're leveraging.
Okay.
We receive those real-time notifications through CMT feedback.
And the transitions to care work group is already working on that. Is that correct?
They're
On
on the Eddie side, yeah. So, yeah.
I think kind of to Dr. Morgan's point to others is that, we have all the players from all the groups involved in each of the different work groups. If we could identify some common things, like you said, referral from ED to behavioral health, that, just a simple set of 3 to 5 things that we want to use across all the work groups, that would make a huge difference. That's where you can bring them all together. Is we're all in agreement that primary care and behavioral health once to ensure that when the patient gets discharged, they get referred to behavioral health, and we can get the acute care providers to agree with that. You can move the measure very well.
Is there a consensus that follow-up is an opportunity for the near term to be one of those small number of priorities? So that's follow-up at 7 and 30 days? Does that align with priorities across the group?
I would say yes from a behavioral health provider
for sure.
perspective. I'm going to say yes.
How about from the hospital side, other hospitals? Any opportunity to collaborate, at least pursue how we might be able to build some bridges on that? Okay. How about the asthma one? That seemed to be another one that has popped up on both radar screens. Medication management for people with asthma. We're kicking off integration of primary care into behavioral health land this week. So there's opportunities for those people with asthma and behavioral health conditions, as well as certainly on the primary care side. So it affects both worlds. Lots of community environmental factors that potentially could be addressed through some collaborative work. What's the sense on asthma? Yes.
Is this measure the same as the HEDIS measure where they have to be compliant for 75% of the year? That may be part of the issue. Is that that's what we see in the community health center world, where we don't have the information until late into the year. So I don't know if this is a rolling year. I don't know if it's counting the whole year or if it's counting all of just 2017. If that's the case, then we have it by June 2017, we have a net 75% of the year. So I don't know if that's the reason why they're red.
So one of the things is we may be over-diagnosing and using codes when people come in for colds and things like that, or, you know, and there's some specific criteria that the state may be using, and we are not as providers, so we're coding wrong, and a lot of these patients are falling into the asthma diagnosis code when they're truly not, who would meet this measure to begin
Well,
with.
there should be only persistent.
Yeah, but I would guess with non-specific coding, we are calling patients asthmatics who just have occasional intermittent problems. And that probably takes our N way high and our results real low. And so that may be one of the first things that needs to happen if we're going to improve this, is diagnose them right in the chart, stop using certain codes if they don't have that.
Well, and I'd like to add something to the coding piece, because in the behavioral health world, and I could be wrong, but from my short experience in the behavioral health world, the coding, what you'll see is at least in our building, therapists will typically just stick with a therapy code when they're actually doing a crisis code or something else, or a case manager will just stick with a case management code and they're actually doing something way different. They kind of just have this is our code. So at least in our building, coding would be really helpful in regards to this is how you actually code correctly. But sometimes even in our crisis department, they may be coding totally wrong, falling into.
But this really cuts across all payers.
Well, and the asthmatic people I kind of felt like that was more of a diagnosis issue, not necessarily a coding issue, but at least for my building, it was, and I could be totally wrong on that one, but my building, our building, therapists just tend to stick to a therapy code, case management code. And it usually,
because the belief is it doesn't matter, but the problem
really,
is
right.
it matters on the far end, and we've had the same problem convincing our doctors of the same thing. You've got to code to the highest level of accuracy, otherwise you're going to be told you're wrong by some governmental agency who uses claims data to see how well you're doing.
Right.
And so it's something that every one of we have to do, and we all have to take this on. We're having problems with it too.
So could I add something that Carol Mosier is the executive director of the Greater Columbia ACH Yakima Tri-Cities area, and they hired on their staff a former Qualis person who specializes in coding, and she has told the rest of us ACH directors how exciting that is. I don't know if they've done it once or twice, but we easily could try to bring that person here. And
it's coding is really specific, and it's almost for every type of specialty you need time and repetition. It's a big thing. So it's, I mean, whether the ACH should be sponsored, I think maybe a good thing to look at. It's a big.
And it may have to be segmented to a degree in terms of the coding training.
So Roger,
Yeah, this is, could I weigh in? This is Tony Butrell up in Leavenworth. I just wanted to add that from a primary care standpoint, it's really helpful if you have a coder that is specified to look over things. The last thing we need at the end of a visit is to spend a bunch of time. It's amazing how time consuming it can be to find that right ICD-10 code. I feel like our job is to get the documentation right, which in and of itself can be a fairly burdensome process, but that's our role. I don't know that it's necessarily, at least from my standpoint, our role to then spend a bunch of additional time looking for the right code. And I point that out just for the managers and stuff out there to try to provide a layer of support for your clinicians so they can do their work and have somebody else looking over the coding.
Peter?
So Roger, I think you've been queuing us up. I mean, it sounds, we have a lot of engagement and a lot of hypotheses that are being thrown out, and I think a lot of interest. I'm wondering what, what a step forward might look like. I mean, there are any number of roads we could go down collectively to solve this, and I'm also thinking that if we were to drill down into each organization, you'd find tremendous variation in how organizations are dealing with this. People that maybe actually have it pretty well dialed in and have good processes, and others that don't. I'm just, I'm trying to think about how we as a collective might go to the next level.
So any thoughts on that before I opine?
Well, this is Richard at Samaritan. I know, we've done quite a bit of work on the inpatient side to focus on provider documentation, make sure we get the ICD-10 codes that are complete and accurate. And I know that sort of work is moving into the outpatient arena, and clinical documentation specialists are getting engaged with quality metrics and assuring that that documentation and the quality metrics align. So perhaps there's some opportunity for more clinical documentation improvement or review to be done in the clinic setting in regards to some of these diagnoses such as asthma.
Okay, any other thoughts? Yes.
I just wanted to volunteer one more thing. I know Nolene and I'm assuming the other carriers as well, we call them HEDIS toolkits that go in detail into exactly what the coding needs to be to capture them for some of these same measures. So it seems like our quality improvement people, to the extent we, as a region, you say, yes, this is a measure, we would hopefully bring them in and at least share that information so you're knowing at least what we're looking for to make sure the coding's accurate.
So I'd like to put a proposal out to the group that kind of tees up some of the future work that we might be able to do in this this meeting as we move forward in this leadership section. So what I would like to do is to create a placeholder for two topics. One is this, again, this follow-up, 7 and 30 days, as well as the asthma management as two starting points. And what we could do is a bit of a deep dive to come back to you and have mapped out what is the current work that's going on in the different work groups and others that align here, and what opportunities are there to move forward and systematically addressing this and making sure that we're coming up with some of the execution strategies and helping leverage all the good work that's going on. What we could do is in the work that we're rolling out in the trainings and in the lands and other activities is to try to make sure where possible we're cross-referencing to these areas as priorities. And if they're available and we can work on them, examples on how people can go back and apply the learning that they're doing, help move these dots. I'd like to use this as a test if we can to see whether there are opportunities to move it forward. I do want you to know that this is a snapshot, and the next quarterly report I think is coming out next week, Caroline, something like that?
Yeah, they'll actually have the true baseline for calendar year 2017 released this month.
So a new one's coming out this month. The data may shift, who knows? And so what we can at least do is some homework to come back and see what the opportunities are and then engage you on what we might do further. And then you can help shape what are some of the learning opportunity priorities. Is coding one that is the highest priority. It sounds like we should start working on that and include that in the planning. So that might be for both behavioral health, primary care, and the hospitals. And then see what other initiatives might be folded into that strategy. We'll bring back data, hopefully, if it's available by next month, be able to bring that back, see what the data shifted, and then if there are shifts, you can make a decision whether you want to focus on other higher priority issues or continue to work on these as low-lying fruit. Does that start to get to a game plan as you suggested?
I mean, I think people have demonstrated a desire to learn from each other here. I think that's an important aspect of the collaborative. And, you know, getting into the details a little bit of where the problems really are and the ahas that might go off in certain organizations, I think would be helpful.
In the asthma area, are there any other areas that are of interest to pursue that have not been addressed as potential groups to engage that should be at the table, or other best practices or pathways that come to mind that we should be considering as we put this map together? Are you noticing any difference with subpopulations in any way, or is it the migrant workers who are, you know, being exposed to pesticides or other issues, or other factors that we should be thinking about and starting to better understand what the data are telling us? Or other data we should be looking at from other sources that would inform this measure beyond just the HEDIS data that's being collected?
I guess, has there been any work to figure out this information? I don't know if there has been. We've got a result. We know our score, but we haven't dove in to look at the reasons of this as a region.
So for those of you that have capacity or any internal resources where if you have data analysts or others that are looking at your data, you know, starting to look at your population that falls into this category, and what do the data tell you? Is there some hypotheses that were already thrown out that some of it may be data integrity issues? So are they falling outside of the reporting period? What percent? You know, if that's 40%, well, wow, that's something that you might be able to move that dot or adjust it to be able to show what the reality is of your performance. If it's other factors, it's environmental or other things, then, you know, being able to surface that to see what we can find out. Any other thoughts on the asthma? Any other discussion items that you want to put on the table relative to moving the big dots? Any other priorities that you saw that you want to throw out? Yes, Peter?
I mean, I would rather other people speak, but I do have questions. And I'm wondering if the MCOs can chime in that, you know, these quality data are, you know, they're important indicators, but if one were to do a deep dive into the hospital utilization data, I'm wondering if one would find, you know, outliers in terms of diagnoses or conditions that would warrant further attention, even if they don't show up on the you know, outpatient clinical indicators. I mean, I'm one of those that thinks of every hospitalization as a potential breakdown in care, and would, you know, look at it that way. I'm just, you know, but I think the MCOs would be the ones that would be the keepers of that and would know where they think money is being spent unnecessarily and might be willing to weigh in on where upstream interventions might be useful. Just an idea.
So that brings up an issue that was referenced earlier about transparency. And we talked about homework being transparent and being able to see what others are doing. That's all in the spirit of shared learning, so that we can see what initiatives, what best practice approaches, and learn from each other. But very soon you're going to be reporting on the quantitative measures through the reporting system and feeding that data. And those data hopefully are going to be a little bit more sensitive than the encounter data. You're going to be able to start to see some of those measures and opportunities that we might be able to drill down further on that data and information. I think there's also opportunities to be transparent working with our payers. If we can get a guiding principle in place within this group that we want to be able to start to learn on what our real performance is on some of these measures across those that are participating in this collaborative so that we can begin to see where best practices exist and where the gaps and opportunities are. If we do that, then we may be able to really drive performance. I see a hand raised.
Yeah, I would say for America Group, we committed to providing quarterly updates on HEDIS metrics for every ACH, and we'll do that by county. And then if there are additional data requests that you have, we can go down as far as county, all the way to the provider, and all providers and collectively sign an agreement that says that they're okay with that, just to not violate any contracts you have. So if there are certain, especially certain diagnoses that we'd like to make sure you're keeping track of, we can include that in our quarterly data reports. Have one ready to go and get out of the integrated managed care world. Get back into ACHs and send it out to people.
So I'd like to put that concept on the table and have you think about that. Another comment? Yep.
Oh, and yeah, this is Laura from Molina, and I think the same is true in terms of reporting. I think we've actually already shared some at county level with the ACH for the HEDIS metrics. We can share directly with our provider partners. It's just we can't provide patient level data to anyone other than our provider partners directly. And the only other thing in response to what you were saying, I think that's a really good idea for us to zero in on our high cost outliers. I know Molina's been looking. I'm only familiar statewide, though I haven't really focused, or I personally am not aware of most centrals having this issue, but I know we have huge issues with high cost outliers around babies with neonatal abscesses, NAS, neonatal, yeah, born with to drug addicted moms, and then sepsis has been really big for us. So just to throw that out there, I think that is an area where we should be looking into what's driving outlier cases, and is that an opportunity to look at with them and really dive in and see if that is true here in North Central.
Well, I think if you worked with your, you know, if there's enough horsepower and even just one, and Molina may be, since you're probably a larger MCO in our area, but, you know, take everybody's data, not just my institution's data or my physician's data, take all of our data and say, and okay, what are the preventable, potentially preventable admissions that we identify, and then don't just tell me I've got 27% too many potentially preventable admissions. Drill down. You guys have the claims data, and figure out what those diagnoses are, and get them out to us and say, this is where we see it. Now let's work together. Is it a coding issue, or is there a lack of access to social determinant, things that'll help their social determinants, or what is it? And so if we look at the data from the perspective of not just if we're failing, but if we're looking at, what do you see we're failing at? Maybe we do have a ton of asthma. And those all should be potentially preventable admissions, and understand the data from that standpoint. If you guys can aggregate the data for us, do the drilling down, because it is your data, and then present it, and we can all look at it and figure out if it's really applicable or correct, or there's coding issues. So I think we need somebody, because I can't drill into F2HC's data. I can't drill into, I can only do what I do, and it only answers my question, not the question for everybody else.
All right. Would there be a consensus in terms of entering into business associate agreements that would allow for that aggregation of data for the payers, that you're willing to share that and be able to drill down, so that Chief Executive was saying, what are the data telling us? What can we learn? Are the real opportunities? Are the pockets? Is there any geocoding that would inform us of particular populations that are at higher risk for whatever reason? And we can start to figure out what the root causes are, or other problems. Is that something that the group would be interested in? I see nodding heads.
And I'm sure some of that data is kind of out there. It's just, is it correlated then with this type of data?
Yeah. And again, if it's not patient level information, I don't
Right.
think we need
It'd be aggregated.
Roger, can you say more?
There.
Oh, well, I just wanted to say, having been in on this kind of from the inception, that the black hole in the middle of the whole demonstration, HCA gives money to MCOs. MCOs have contracts with providers, and in between there is darkness, because those are private business arrangements. And yet MCOs have often said, what can we do to actually help this have an effect upon the way patients are taken care of. And I think this is just a great idea that helps answer that question and could be a major way to kind of bridge that gap if the MCOs are willing.
So what the next steps would be, I think is what you're probably asking, Peter, to some degree.
Well, I'm thinking you threw out a term of business aggregation agreement or something like that. I think that involves a lot of people being willing to let the MCOs aggregate their data as long as there's no PHI and all that sort of thing in a way that might provide this ability. So I'm not sure what the road map to getting there is, but it involves people signing some things that allow that to happen, right?
So what we could do between now and the next meeting, perhaps, is offline work with the payers and find out what agreement might that look like, and then come back to you and say, here's what's proposed. We would be able to then have the data aggregated, be able to have them use their analysts and their resources to drill down and see if the data inform us in any way of what the opportunities are. Is that acceptable to the group? So to wrap all of this up, the next steps are that we hope to come back with the updated data from the state of what the current performance are on the metrics. So that may or may not shift the priorities. In the meantime, we're going to focus on follow-up after hospitalization and asthma as the three metrics that popped up here on the screen to see if we can step back and kind of map what are the various activities that are underway and the learning opportunities are fitting into that, and come back to you at the next meeting to say, here's what the landscape is. Now let's see what needs to be done. Do we need to get coding classes or other types of things that will help us? And we'll come back with a sense of these business agreements or whatever is necessary to aggregate the data. Any questions on that? So we're hoping moving you towards more reflecting on the data, helping to prioritize where we can collaborate, creative brainstorming on approaches and solutions to this, and prioritizing the learning opportunities as we move forward that align with your strategic priorities. Does that seem to make sense? All right. I think I'm on time.
We're on time. Thank you.